I'd like to say this is a continuation of the meeting we had last week. I mean, the topic is still on anterior abdominal wall defect. I'll also probably cover a little bit of the intra-abdominal defects. I'm not sure to what extent. We'll see what time allows us to do, but probably this presentation may be carried forward to next year when we resume our meetings. Like I said last week, that we'll be taking a break this week. That means the next week there's no meeting. We'll take the holiday break and we will meet again in January. I'm not sure, was my second device taking long to show the screen? Is there a way of someone notifying me if the screen has arrived to where you are? But basically, this is a representation of the most of the defects that we are going to be talking about. This is how they look extrauterine when the baby is delivered. So you can see for yourself that this is an exomphalos characterized by a membrane covering the intestines and the umbilical cord inserted somewhere at the dome, not necessarily at the dome always, to be honest with you. Some are slightly on the side of the sac. Some may be here or there. Although I know literature says they should be at the dome, but it's not the case in practice, always. So, and then we have gastroschisis. Gastroschisis, you can see the intestines are all over the place. Is my screen visible where you are? Can someone please respond? I want to know if my screen is visible, because
yes, it's visible.
I'm struggling to get it on my second device. Can you guys see the screen in front of you?
Yeah, on my side, the screen is visible.
Then okay, let's see the message there. Ah, perfect. So you guys are getting in. Right. Then we, the next condition, you can see gastroschisis is easy. The bowels will be outside when the baby is born. So very easy to distinguish from exomphalos. Exomphalos always has a membrane, very nice membrane there. Then we have the gastroschisis. Then we have the body stalk malformation. The body stalk malformation is marked by a large defect on the anterior abdominal wall, so that most of the contents, including the liver, are out. Body stalk malformation is marked by premature rupture of the membrane, so that some of the contents of the baby are actually outside the amniotic membrane, and the liver may actually be directly attached to the placenta. And these babies normally come with severe deformity of the spine. So they have kypho scoliosis. They may also have other amniotic band patterns. Remember, this is due to early rupture of the membranes, and it disrupts the anterior abdominal wall. So they may have other features of amniotic band pattern or syndromes, such as amputation of the limbs. They may be seen there. Then we have pentalogy of Cantrell. Pentalogy of Cantrell is more like an upper, whereby the defect extends to the upper border or to the upper chest, to the chest of the baby. So this is an anterior abdominal wall defect which spreads going upwards, and it breaches the diaphragm, and the liver protrudes outside as well into the sac. So when you have an exomphalos and also protrusion of the liver outside becomes a pentalogy of control kind of a picture. The protrusion, protrusion of the heart, not the liver, the protrusion of the heart. So protrusion of the heart itself is called ectopic cardia. So if it is just isolated heart protrusion, the diagnosis becomes ectopic cardia. But if there is associated abdominal wall defect, like an exomphalos, then the whole complex becomes something we call pentalogy of Cantrell. Then cloacal exstrophy, the defect is a little bit down there, so that it involves the bladder. The bladder area is involved. The bladder may not be seen, or the bladder may be seen to be protruding into the sac. So this is down below, and this defect tends to affect the genitalia. I'll be describing these conditions in detail. So that's cloacal exstrophy, and the umbilical cord does not necessarily protrude. Is not necessarily inserted in the dome or in the sac. It may be in its normal place, but the defect will be a little bit lower down here, and the umbilical cord insertion is on its sac. Probably this is how sometimes you can distinguish it from exomphalos. I thought I needed to revise to bit more with you again the exomphalos, because the importance of these conditions. So exomphalos, how common are they? 1 in 100 at 11 weeks because of the physiological exomphalos. So if you do scan babies at 11 weeks, you are going to see this physiological exomphalos. Normally, do not panic. Ask these babies to come at 13 weeks. You do not expect to see a physiological exomphalos at 13 weeks. Remember, exomphalos is also called omphalocele. But however, at 12 weeks is 1 in 800, then at 13 weeks is 1 in 2,000. So this is the reason why I'm saying ask these babies to come at 13 weeks, so that you get rid of the many cases which are due to physiological, and so that you don't have to unnecessarily worry the parents. So the liver is in the second 1 in 3,500 fetuses at 11 to 13 weeks with an exomphalos. So basically, these are midline defects, and they are sagged. That means there is a sac surrounding the contents. And the umbilical cord, the right that is at the apex, but for those who have been scanning with us, or those who have seen babies being delivered, we know that it's not necessarily always at the apex, but it could be just lateral or so. But the truth is, it's always on the sac. It's not emanating from the abdominal cavity here. If it contains the heart, this is where it becomes pentalogy of Cantrell. That means if the anterior abdominal wall defect is extending, going upwards, it becomes a pentalogy of Cantrell. Then if it is going downwards, where it will cause cloacal abnormality and also spina bifida, it becomes part of OEIS complex or cloacal exstrophy condition. So exomphalos contain bowel only at 11 to 13 weeks, resolve by 20 weeks in 90% of the cases. So this is very important when counseling the couples, for them to know that some of the defects you pick very early on, they have the opportunity to resolve, especially if the liver is not involved. This is just to show you, especially what the umbilical vein does. You can see that the umbilical vein travels its own course through the liver, if the liver is in, or through the sac, and then it attaches with the rest of the other two umbilical arteries there. Then at the top of the sac, it could be on the side, It's not necessarily at the apex of the sac, but this is how it comes out. So you can see the different types. This is one is a small one. This one is a large one. This is an ultrasound scan image of an exomphalos. This to just estimate the neck. The neck helps the surgeons in terms of knowing the size of the defect that they have to deal with. This probably was more, this was extending very much to the front there. So probably it's more of a pendology of control kind of defect here. So chromosomal defects, mainly trisomy 18 and 13, are found in about 30 to 50% of the cases. So this is why offering these women diagnostic testing, amniocentesis, is very important, because you want to make sure that there is no associated trisomy 18 or 13. Of course, we know that trisomy 18 and 13 will have other features, polydactyly, syndactyly, all those things may be associated with trisomy 18 and 13. So we should always be looking for other features whenever we see exomphalos. Then genetic syndromes, mainly Beckwith-Wiedemann syndrome, is found in about 10% of the cases. So we need to look for evidence of overgrowth, the hepatomegaly and so forth, the face, to try and pick up the Beckwith-Wiedemann syndrome. Then defects in other systems is normally associated with this condition, like cardiac defects, which are found in almost up to half of the cases. So if we pick up exomphalos, it's not the end of the story. The woman will need a detailed scan to rule out associated abnormalities, because the outcome of fetal defects is very much affected by associated defects. Then in terms of the investigations we have to do, we need to do a detailed ultrasound examination, including fetal echocardiography. Then, as we have already said, that we need to do karyotyping to rule out trisomy 18 and 13 or other aneuploidies. Then we also need to do molecular testing for Beckwith-Wiedemann syndrome. Then in terms of the follow-up plan, this is a classical case, how pedology of control case looks. Look, this is a heart which is protruding through the fetus chest there. So ultrasound scans every 4 weeks to monitor for fetal growth and amniotic fluid. It is always best to use the CM formula, which is biparietal diameter, ospitofrontal diameter, and female length to do the weight, because we know that the liver, if it is out, the size of the abdomen is affected, and we may underestimate the baby size. So unfortunately, the CM formula is not available in our machines. So we find ourselves just having to measure where the liver is. This is what we do. We try to measure the part where the liver is, because look, the liver, to me, is a surrogate marker of nutrition in the fetus. So we try to measure the sac that contains most of the liver. But we are aware that this may grossly underestimate the actual weight. Then delivery. These babies are not supposed to be delivered outside tertiary centers. Yes, they need to be delivered in a hospital with neonatal intensive care and a pediatric surgery. Very important, very important. Please, no one should be brave enough to say baby can be delivered and transferred. That's a disaster. Then the timing is 38 weeks. They have to come out at 38 weeks. If there is evidence of FGR or fetal hypoxia, of course, we may consider them to come to be delivered early. In terms of the method, induction of labor, aiming for vaginal delivery is possible. Then cesarean sections are reserved for obstetric indications such as breech preservation or for giant exomphalos, whereby the sac contains more than 75% of the liver to avoid liver rupture and the hemorrhage. So please take note of this. So if the liver, I think we have had these kind of cases at Sally where the liver is inside the sac, or all of the liver, almost all of the liver, and we have delivered them by cesarean section. It does not necessarily mean that all exomphalos have to be sections. It's only if the majority of the liver is in it. Then in that case, C-section is the best mode of delivery. The prognosis for small and moderate exomphalos, survival is 90% if managed properly, if good neonatal care is given, and if they deliver at the right center where there is both neonatal intensive care and we have the right people to look after them, and we have pediatric surgical teams who immediately look after these patients. If they are delivered outside, the mortality is probably less than 20%, the survival is less than 20% if they are delivered outside these kind of conditions. So that means prenatal detection plays a very big role when it comes to the survival of anterior abdominal wall defects. Prenatal detection and in utero transfer. You don't detect and deliver at your hospital without these facilities. You do in utero transfer. The isolated giant exomphalos survival is 80%, again with the above conditions. We sometimes fail to meet these conditions and our babies do not have a good outcome. One of our students is looking at their outcomes. We'll know very soon what is our outcome here locally for this kind of babies. Other defects depends on defects. Trisomy 18 is lethal, so is trisomy 13. So if we have trisomy 18 or 13, these conditions are lethal. So ruling out association is very important in terms of counseling the couple so that they are aware of the prognosis issues. Because if you told the couple that, look, survival is more than 90%, yet you have not ruled out trisomy 18 or 13, you are going to disappoint this couple because the babies, they will die from the complication of being trisomy 18 or 13. So invasive testing is super important. Then recurrence, if isolated, no increased risk. Then if part of trisomies is 1%, the risk of recurrence. Then for if part of Beckwith Wiedemann, unfortunately, it's up to 50% the recurrence risk. Gastroschisis, you can see from this pictorial representation here that the defect is on the right of the umbilical cord, and these are the bowels which are herniated. They are not sagged. That means they are outside the sac. In this case, you can see them there, floating intestines, fairly common, 1 in 3,000 at birth, and increase in young women and those with cocaine abuse. This is why substance abuse is one of the things that we ask when we are taking history. Well, some may wonder, why do we ask women about substance abuse? This is one of the reasons, so that we know the risks that the pregnancies are exposed to. So it's a paraumbilical abdominal wall defect, usual to the right side with associated evisceration of bowel, which will be floating freely in the amniotic fluid with a normally inserted umbilical cord. So that's how we distinguish it from exomphalos. It's very important to distinguish the two. The incidence of chromosomal abnormalities and genetic syndrome is not increased in babies with gastroschisis. Very important in isolated cases, right? So a detailed ultrasound examination is what we will need. We don't need to do anything special for these babies except this detailed examination. And what are the complications? The complications are bowel atresia or obstruction secondary to volvulus and ischemia at the hernia orifice in about 10 to 30% of the cases. So evidence of ischemia should be checked by measuring the inferior mesenteric artery Doppler to check if there's any evidence of constriction or evidence of stenosis of that vessel. Then fetal growth restriction occurs in about 30 to 60% of the cases. Because of this, these babies will need serial fetal growth monitoring. Spontaneous preterm birth in about 30% of the cases occurs, and fetal death demise may occur in about 2 to 4% of the cases. So in terms of follow-up, I've already mentioned that they need to be monitored growth. So every 4 weeks, they need to come for fetal growth assessment where we check the amniotic fluid and fetal oxygenation, where we do the umbilical PI, MCA PI, and the ductus venosa PI. The very same things that we do when you are assessing growth, and also the intra-abdominal bowel dilatation. We have to check for that evidence because that's a poor prognostic marker if the bowels that have remained within the abdomen are now dilated. In fetus with abdominal wall defects, this is based on motor growth through estimation of fetal weight by CM formula again. But however, we do not have this CM formula. So for now, we are stuck. We'll try to see if we can have it put in the FetalMed application so that it becomes an option for us. But that's the best way to estimate, because obviously the gastroschisis is going to affect our measurement of the abdominal circumference. Then delivery, again, a place with neonatal intensive care and the pediatric surgery. The timing is 38 weeks. Earlier, if there's evidence of FGR or fetal hypoxia or dilatation of intra-abdominal bowel of greater than 20 millimeters. The fear is that if we keep them those with the dilated bowel, those bowels may become dysfunctional through obstruction, and the baby may suffer from severe short bowel syndrome. Then the method, induction of labor, aiming for vaginal, there is no good evidence that cesarean section is beneficial. So our gastroschisis, if they are not fetally restricted with evidence of hypoxia, they can be induced, they can be delivered natural if there are no obstetric contraindication to natural. Then prognosis, survival is greater than 90%, provided the conditions above are met. The right hospital of delivery, the right perinatal is not the right hospital. It doesn't have pediatric surgery. For your information, because some may say, okay, so we can deliver them at perinatal. No, you can't deliver them at perinatal. They have to be delivered at Salim Gabe because that's where the pediatric surgical unit is. So please, let's get this correct. It's very important because if you deliver them at the wrong place, they will die anyway, and your prenatal detection will not change the outcome. There's nothing as frustrating as seeing prenatally and you still don't change the outcome. Then people will question and say, why are we seeing them anyway? Why can't we just leave them alone if the babies are going to die anyway, irrespective of whether you guys pick it early or you don't? So very important to take note of this. The same way that UBH is not qualified to deliver them because they don't have a pediatric surgical unit, they have to go to Pari or to Mpilo. No other hospital in the country should be delivering gastroschisis and exomphalos. No. If you do that, you kill them. So very simple. So let's take note of this and also educate others because there are people who think their hospitals are so special and they can deliver whoever they want. But look, it's about babies going home here, being survivor. So the prognosis is more than 90%. And if we deliver them at the right place, the main cause of death is short bowel syndrome. However, in our setup, because they are being delivered at the wrong place, the main cause of death will be dehydration, electrolyte imbalance, and infection, because they are delivered at a wrong place where the bowels are delayed to be covered, and where nobody out there knows how to hydrate them properly, and they suffer from a dehydration, the electrolyte imbalance, and sepsis, and they die. So the recurrence risk is about 3%. Body stalk anomaly is the next one. So body stalk anomaly, what is it? So the body stalk anomaly, if you look at this image from the FMF, you can see the amniotic membrane. Remember, I always talk about the chorion and the amnion, and that the two are separate before 15 weeks. This is a 13-week here. So you can see the amnion, that the amnion is literally sort of ruptured here, and these abdominal contents have gone into the chorionic cavity here. This is the chorionic cavity, because the chorionic cavity and the amniotic cavity they are sort of separable before 15 weeks, before the chorionic cavity is obliterated. So you can see that there is a rupture at the place where the abdominal contents, anterior abdominal wall contents have sort of herniated into. So these babies, normally you may not see the umbilical cord, but what is happening is that the liver will be directly attached to the placenta here. That's how the baby will be fed. It's a very bad defect. So it is as common as 1 in 10,000. We have seen more than 5, I think, if my memory is well, we'll see from the data from the anterior abdominal wall defect study. But we've seen more than 5 of these cases, so they are fairly common, but the literature reports them as 1 in 10,000, and they are more often in young age group and cocaine abusers. Substance abuse is coming again, so please do not take asking substance abuse lightly when taking history. Very important. Ultrasound, you are going to see a major abdominal wall defect with severe kyphoscoliosis and a short or absent umbilical cord. Typically, the liver is directed towards, directly attached to the placenta without interpose umbilical cord, and there's a major distortion of the spine. The incidence of chromosomal abnormalities genetic syndromes is not increased, so we do not routinely offer amniocentesis to these babies, to these women, and encephalocele or fascial cleft or limb amputations are common. Why? Because they are part of the amniotic band syndrome kind of conditions, whereby the amniotic band may also go through the baby's head, go through the baby's limbs, and amputate them. So be aware of this, that this is more of a very complicated amniotic band syndrome kind of condition. Yeah, so everything will be out and looking a little bit uneasy to the eye. You can see the liver out there. Yeah. So investigation, detailed ultrasound scan, and if the mother does not opt for termination, normally routine follow-up should be given. There's nothing special you have to do. You don't have to say come every week or every 4 weeks to check the baby. We just see them routinely. From the time we diagnose them, we can just do them a 36-week scan to just make sure there's nothing that will impinge vaginal delivery. And routine obstetric care and delivery should be offered. The condition is lethal in utero or in early neonatal period. So it's a lethal condition, body stalk anomaly. So please don't tell women that, look, your baby may survive, your baby may what. This is a lethal. Lethal, that means the condition kills, period. There is no increased risk of recurrence for this condition. Then bladder exstrophy. I do not have an image to show you, but for this condition, you are going to fail to see the bladder. Prevalence is 1 in 30,000 and more common in males than in females. Bladder exstrophy with a ratio of 2:1. The ultrasound scan diagnosis, there is an abdominal wall mass in the suprapubic region below a low insertion of the umbilical cord. So we normally suspect it through a low insertion of the umbilical cord, and there is non-visibility of the bladder while the amniotic fluid is normal. So there will be no bladder visualized. You remember last week I showed these screening images for anterior abdominal wall defect where we saw the bladder. In that image, or even in the sagittal plane, we are going to fail to see the bladder. And if we look from the top, scroll from the top with the baby putting spine down, you are going to see widely separated pubic bones with short and broad penis in males and a hemiclitoris on either side of the bladder in females. The incidence of chromosome abnormalities and genetic syndrome is not increased. Delivery, hospital with neonatal intensive care and pediatric surgery, and the time is 38 weeks. Induction of labor can be done aiming for vaginal delivery. The survival is very good. It's 95%. The surgery aims to achieve bladder closure and urinary continence and epispadias repair. However, one of the main complications of this kind of condition that normally it's very difficult to achieve total bladder closure and also urinary continence. So unfortunately, survivors of this condition may leak urine throughout their lives, which makes it the quality of life very difficult. The recurrence is not, risk is not increased. Then we go to another condition called cloacal exstrophy. Probably before I describe, let me show you some images. So cloacal exstrophy, we can see that we have the umbilical cord coming out at the right place, but we have what looks like an exomphalos below the umbilical cord here, where the abdominal contents are within a sac. And we don't see the bladder because the bladder is also involved in this defect. So this is cloacal exstrophy. You distinguish it from an exomphalos because you are going to see a normally inserted umbilical cord on top of the mass. So you need the sagittal plane to see this kind of abnormality and the non-visibility of the bladder in its no usual place here. And it's very low down, extending all the way to the perineum, the abdominal wall defect. So this is a lower abdominal wall defect. So how common is it? As common as 1 in 300,000. So in this image, you can see the stomach sometimes is in it, the bladder pulled down into the sac a little bit there. It's a low, so ultrasound scan diagnosis, we're going to see a low exomphalos. We're not going to see the bladder. We may see sacrospinal bifida in about 50% of the cases with normal volume of the amniotic fluid. The anatomy of the cloacal exstrophy is complex, but essentially there is a low exomphalos at the superior margin of the defect, a small or large bowel protruding through the middle of the two widely separated hemibladders, and the hypoplasia of the colon, and anal atresia, splaying of the pubic bones, bifid penis in males, and the hemiclitoris on either side of the bladder in females, and the spina bifida. So it's an ugly defect, as you can see from the description. What is being described there, I believe most of you never thought this kind of things could actually happen, where you see a bifid penis, two penises on a baby, or two hemiclitoris. It's something that you may find difficult to imagine, but this is how bad the condition is, called cloacal exstrophy. The incidence of chromosome abnormalities is not increased. Other defects, mainly renal and vertebra, and talipes, and single umbilicatory and ambiguous genitalia in males, the penis is divided and duplicated, are often found. So the investigations, we do a detailed ultrasound examination, and then we do invasive testing to determine the genetic sex of the fetus, because sometimes the sex may become ambiguous, or it may be, difficult to determine using ultrasound. Then again, delivery, if the mother chooses to keep the pregnancy, because in this case, ovarian termination may be an option with this kind of defects because of the debilitating effects, and also the poor quality of life even after surgical repair. So if the mother chooses to keep the pregnancy, delivery again is at a facility with both neonatal intensive care and pediatric surgery. The timing is 38 weeks, and induction of labor aiming for vaginal delivery is the way to go. Survival is greater than 90% after extensive reconstructive bladder, bowel, and genital surgery. So this is an extensive form of surgery we are describing. Both males and females with this condition are capable of normal lifestyle, and both sexes are fertile. After some form of urinary tract diversion is required for all. No increased risk of recurrence. So I'm done with the anterior abdominal wall defects. So what I've just done is I've taken it through gastroschisis, exomphalos, body stalk anomaly, bladder exstrophy, and cloacal exstrophy. So the distinction between cloacal and bladder exstrophy is that normally in bladder exstrophy is only the bladder. We do not have abdominal contents coming out. And you don't not have the other anal and so forth defects. However, the issues of hemiclitoris and bifid penis may still exist in bladder exstrophy as well. So, and we do not have a bifid bladder because the bladder may be bifid in the case of cloacal exstrophy. So these are the anterior abdominal wall defects we have to be aware of, and we have to be able to detect. I know I've got maybe 5 minutes. Within these 5 minutes, maybe let me talk about esophageal atresia. Then we know next year we'll move on from this, from esophageal atresia. First of all, there's a large classification of esophageal atresia. It is important for us on the fetal medicine side to just have an appreciation of this. If you look at the type 1, which is which makes up 10% of the tracheoesophageal fistula, the TOFs, you can see that there is non-communication. This is the esophagus and the stomach here, and then we have the duodenum going forward. And this is the trachea, and of course, the 2 bronchi there. So for this type, you can see that there is totally no communication here whatsoever. So this type is going to manifest with non-visualization of the stomach, and there will be no, increased amniotic fluid. This type again, there's totally no communication. The type 2, they are slightly different. We know the esophagus is feeding there, but there's totally nothing in terms of connection with the stomach. So again, for this type, you're not going to see the stomach. Then we have the third type. You can see that there is some fistulation there. There's some fistula where there is communication with the stomach, because fluid can still go through the trachea, because remember the baby also inhales fluid into his trachea. And for this type, we may see a small stomach. But for this type where the esophagus at the top is totally feeding into the trachea, we may see a normal stomach. So what it means is that if we are to use non-visualization of the stomach to try and pick up esophageal atresia, we may probably pick less than 20% of the actual esophageal atresia, because the 88 to 89% of them, they will have some stomach of some sort because of the fistula between the trachea and the lower esophagus, as you can see. So be aware of this, that sometimes if you see a small stomach, you might want to bring that patient back after some few minutes to just confirm that indeed the stomach is growing in size, or just a small stomach. A small stomach can be a marker of type 3 or type 4, mainly type 3 esophageal atresia. The other types, we may, like type 4, we may have extreme difficulties in picking it using ultrasound because the stomach will be very tiny. So be aware of this. So how common is it? As common as 1 in 3,000. And normally we see a small absent stomach in the presence of polyhydramnios after 25 weeks. So polyhydramnios is a very good marker which we can use. So here you can see there's no stomach, but in this image you can see a tiny stomach highlighted there. Then esophageal atresia may be suspected prenatally in only about 40% of the cases, because if there is an associated tracheoesophageal fistula found in more than 80% of the cases I've shown you, the stomach may look normal. Then chromosomal defects, trisomy 18 is20% of the cases, and trisomy 21 in about 1%. The other defects are mainly cardiac, which are found in about 50% of the cases. Then we have tracheoesophageal fistula, which may be seen as part of the VACTEL association, which include the vertebral, the VSTs, the anal atresia, tracheoesophageal fistula, and renal anomalies, radial dysplasia, and also single umbilical artery. The investigation detailed in ultrasound, including fetal echocardiography, and also invasive testing. I forgot invasive testing. We need to offer them invasive testing because of the association with trisomy 18. Then ultrasound scan every 2 to 3 weeks to monitor for fetal growth and assess amniotic fluid. Amniotic drainage may be necessary if there is polyhydramnios and cervical shortening. The delivery placed with the neonatal intensive care and pediatric surgery, timing 38 weeks, induction of labor, aiming for vaginal delivery, no need for C-section unless obstetric indication. In terms of prognosis, cervical is primarily dependent on gestational at delivery and the presence of other anomalies. For babies with isolated tracheoesophageal fistula born after 32 weeks gestation without aspiration pneumonitis, postoperative survival is greater than 90%. There is no increased recurrence risk for the isolated cases, but if part of the trisomies, the recurrence is 1%. So this is how things look on this picture there. You can see that there is non-continuation of the esophagus attached to the trachea there. And now during the repair, they just have to remove it there and attach here. The repair in most cases is not extremely difficult, but of course our pediatric surgical team will be able to say it better. So this just show you the normal picture and then where the esophagus is dilated here. It's extremely difficult to see, but you should be aware that we can see a dilated esophagus and effort should be made to look for it. Right, so I think I want to stop here because of time. So when we meet next year, we will cover duodenal atresia and many other intra-abdominal wall defects that we have to suspect or to pick up. Otherwise, all the best. Wish you a Merry Christmas and a Happy New Year, and bye-bye, because this is the end of our talks for this year. We will meet next year to continue the fetal anomaly series. I think after fetal anomaly series, we will do the placenta pathologies, then I think the preeclampsia screening, yeah, I think we'll be done once around February, everything else will be done. Otherwise, bye-bye in terms of the